Hi everyone and welcome back to the HP Leader YouTube channel, and today I am delighted to be hosting a whole day event on cardiorespiratory rehabilitation, especially during the COVID-19 pandemic. So our next speaker is here. This is an hour session. We've got two speakers and I'm not going to steal any more of Jane's time. I'm going to hand over to her to let her introduce herself and share her slides. And just a reminder, any questions go in their YouTube chat box or just DM me on Twitter or tweet, just tag me in. Thanks, Jane, over to you. Now, Jane's internet has been a bit unstable today, everyone. So if we do lose it, it's not her fault at all.
We've lost it, haven't we? No, I think so.
So the screen share worked fine before, didn't it?
Hi there, Rachel, are you there?
Yes, we've got you. We've got you. Don't worry. I've just introduced you. If you just wouldn't mind sharing your slides, and then we can get going. We should have kept them up. There you go. Brilliant. Thank you, Jane.
Hi there, everybody. Hi, everybody. I have a particularly unstable internet connection today, so apologies if anything goes wrong, and hopefully Rachel can pick up the pieces if it does. So my name's Jane. I work up in Ayrshire, which is about 20 miles from Glasgow. We're in Tier 4 restrictions at the moment, which means near a full lockdown again, like many of you across the 4 nations are experiencing just now. I manage cardiac and multimorbidity rehabilitation, and that multimorbid concept has been one that has been building over the last few years. So we offer a tiered model of rehab where Tier 4 is your specialist rehabilitation that happens like cardiac, pulmonary. So our background is cardiac. In addition to that, we do Tier 3 rehabilitation, which is for people with multiple long-term conditions. So that increases the access to a rehab concept for people with falls, diabetes, stroke, cancer, as well as angina, the cardiac conditions that don't always get included in specialist rehab. Tier 2 is our leisure rehab. We co-deliver with leisure across some of our programmes. And our Tier 1 is our links with all the community and voluntary groups that exist out there across our local authority. In addition to that, we have Tier 1 peer supporters that exist previously in all our classes and buddies for our service users. We try to have a seamless transition between any tier in our service. Like everybody has talked about today, the challenges COVID has brought us mean that there are challenges across all of the tiers. So Tier 4, all the physiotherapists returned to the wards. So there was absolutely zero physiotherapy or exercise-based input to any service user in that time. Tier 3 stopped absolutely completely. There was no multimorbidity contact, nobody seen with anybody that was experiencing long-term conditions. Physios returned to the service with really stressed with a massive backlog of patients, dealing with patients with that heightened sense of loss, frailer people, and grieving, as we still may be, for our previous service and the groups and the opportunities that that brought us. No Tier 2, no new referrals being accepted, gyms closed intermittently, on, off, and absolutely no group situations. Tier 1, our links with all our leisure, third sector based colleagues. all staff furloughed, reductions in funding and fundraising, and all the support that the third sector offered previously was changed, reduced. So we're just trying to find some safe solutions to move forward to meet the needs of those people that we were experiencing during that phone call triage period. So we dreamed up on a nice sunny day the birth of a cardiac rehab outside check-in. I honestly believe that that was the most simple solution that we could ever think of, and yet that management deemed this a really high-risk solution, and we had so many loops to jump through. Mountains of paperwork, risk assessments, procedures, checklists, new documents, environmental checks, all meant that it all seemed super challenging to get such a super easy concept off the ground. So the concept was it would be a 4-week structured check-in using local parks to facilitate physical activity, pass over information, reassure, assess using more of a visual, gaining access to the multidisciplinary team over those 4 weeks, building the relationships through face-to-face, and using it as a turning point for people who absolutely had told us that they were struggling over the phone consultations. So we called it CROC. It began with the telephone consultation. We structured it so that week 1, we dealt with physical activity and meds. We found that many people had not even left the house, so siting it in a park and allowing them to walk around the pond while we were still in the car park was a really useful thing to be able to do. We talked about their meds in that week 1. Week 2, we moved on to signs and symptoms. We backed this up with handouts, did checks on them, and then checked in, are they still walking? Are they doing their own walking? Were they doing something else? Week 3, using the questionnaires that we had earlier used, we triaged people into either seeing OT for mood and anxiety management type issues or concerns, or the weight management side. Week 4, we then covered risk factors, tied things up with their behaviour change, and at that point we discharged them from our service. We tried to make decisions about how we included and excluded people. We were still aware that though we were in the park, there were people were concerned about that. We didn't know how it would be seen. We didn't know how it would be viewed. We knew that whatever we did, we had to ensure that it was perceived to be safe, even if we felt it could justify it to be safe. And we knew that part of that is not just making it an open offer. So our inclusion criteria included failing to progress. They haven't left the house, and this was not normal for them. They were showing high scores on HAD. They were describing symptoms of anxiety. They were unable to return to their normal life. They needed the skills of more than one person, and those phone contacts, either or the offer of near me, was not leading to a sort of positive response to that. We excluded from park rehab those who were doing absolutely fine, those who were self-managing, out and about, exercising, and were symptom-free. Those who were shielding or who have been advised to shield because they were particularly high risk, as in those who were heading in for a hospital operation. That's more applicable at the moment if people have an investigation where they're being asked to stay in for 2 weeks. As ever, people decline even when you think something might help them, they can decline it. And people who are normally housebound, and if they were describing really unstable symptoms. Nothing went completely simply. So we had usual challenges, and particularly as time has gone on. So it was designed in the summer when we had much more nice weather. We have in the top corner a grey day, a grey wet day. That's not too bad, but we've had such windy days here. We've got one that's at a park near a beach and a sand dune blew into the boot. We have dogs, we have patients bringing their dogs that intertwine themselves without us. We had a car park that turned into a building site. We had a car park where the traveller population moved in, and we had a car park that was so filled with other cars that no staff or patients could get parked there. So it certainly has been with its challenges. But like everything else, everything that you do has to be built around evaluation and getting feedback about what you do. So the very first 6 weeks, over the very first 6 people over 4 weeks, we then sought all their views about how they'd found it. And we repeated their questionnaires. So we use HAD, like many teams do, and we use a cardiac rehabilitation patient-related outcome measure that's specific to cardiac rehab. And we look at their ratings of health and well-being. And everybody who attended improved both their HAD scores and their ratings of health and well-being. All agreed that meeting in a park or a car park, that it was still suitably private, that they got sufficient information, that their confidence and activities and anxiety improved, and they had all their questions answered. They were impressed by the idea of it. Those lacking in confidence allowed them to share their fears and build relationships within the team. It allowed input from physio, nursing, occupational therapists, and weight management specialists. So to build on this, another part of the work that we do, we mentioned earlier, was our Harp work, which is tier 3, which is the multi-morbidity work. And part of that group of Harp work is some rehabilitation work with people who are affected by upper GI cancer. Some of those people I'd had contact with before their operation. They'd had their operation through lockdown and was picking up contact with them. And by and large, I found a really significant proportion of them were struggling emotionally. They were struggling emotionally with a lack of contact, a lack of support through a cancer diagnosis and lockdown. And if you had poorer home circumstances, I don't necessarily mean poverty poorer, I mean poorer as in support mechanisms, health literacy, confidence, then these people were needing some kind of backup. So we started to look at bringing these people to the park, and I quickly found that that 4-week really structured concept that we'd had for the cardiac rehab people wasn't working as well with people affected by this upper GI cancer. It was always men that wanted to participate. They used it very occasionally as a sometimes one-off. We did target people who their life was more challenging for them. And then we took it to the concept of a walk and a talk, so it wasn't so much of a car park meeting. These people didn't want just a pure and simple weight check or check on how they were managing. They wanted to be able to talk and for these subject matters to occur naturally during that health professional interaction. The downside of that is it's been difficult to find a cut-off point for it all. When we keep things looser, my worry is that we're creating a dependence, and that's one of the things I've actually had to think really long and hard about. How do I make that work? So looking at this group of people, we call them the ROC, the Rehab Outside Check-in, because they're not cardiac. And the feedback's been really nice, but what's been important to them is occasionally seeing people that they knew pre-diagnosis. It gets them out and exercising when mood and motivation has been low. It's given them the opportunity to get quick answers when either they do not want to lift the phone because they don't feel worthy of bothering anybody. And the concept of feeling cared about, it's been really nice for them to talk and realise that someone was listening to them. And they found it better than on the phone or their near me type consultations. And they've always left feeling better. So it seems that no matter what they've done, in any way, shape or form, and listening to all the themes that have happened today, any form of face-to-face has been really gratefully received by any of our service users across the 4 nations. So it's so important for us to keep being innovative in how we deliver, to keep evaluating it, and to keep seeing, no matter what happens in the long term, what are the positive additions to our service that we keep. I'm sure that none of us will go back to doing exactly what we were doing before. Thank you.
Wow, I mean, that is so much food for thought. We have just so many comments on how like blue sky thinking that is, and how if you just had, you know, a blank sheet of paper on how rehab, like alternative rehab might look, that is it. So one of your slide when at the beginning, when you said you had this simple idea, but actually the reality of just getting on and doing it, which we'd actually managed quite a lot of in COVID times, would actually been given the authority to just get on and do a lot of things. Why was this different in rehab? Because this was felt everywhere. Why do you think that was?
I think it was partly that it was seen as, in some level, non-essential contacts with people. And that's made everybody put safety first, and taking safety precautions probably beyond. We wanted to be safe as well. We weren't trying to advocate something that would put people in danger, but we were on the, I suppose, the shop floor, listening to people's barriers, boundaries, frustrations, anger. And so our desire to find solutions for that, I think, has been really strong. And much as I think initially through it all we heard about was tech solutions and tech-based solutions. And we were forced into using many of them, and we've heard lovely examples of how that's worked so well. But actually the desire for contact with real human beings, that was one of the themes that I just heard again and again and again.
And I mean, I love that concept of especially the outdoor activity. And I mean, I work in London but live in Newcastle, so I know the weather divide. It's freaky sometimes how different it is up north, so even more so in the, you know, for our Scottish colleagues. So they're just circumstantial barriers, aren't they, when you think about outdoor exercise or outdoor rehab? And it's almost translatable. So as we head into winter, if you don't provide some form of exercise therapy in those conditions, it's completely unrelatable to what the patient then has to do when they're by themselves or in the 3rd or the 4th or the 5th lockdown. So is that kind of what you meant about having that engagement as well? So with other people, but also the other side of it, so they're in a natural environment?
Yeah, there is a lot of information, isn't there, about green spaces and the power that has to help people. But interestingly, recently, there's also been something else about green space rehab only works if you want it to. So I think it's about being sensitive to people, what people want, and having the options there. And it is all about creating options. So we should never go back the way. We can't undo what we've got. And if anything good comes out of this, it is that we have fast-tracked virtual options. Our web information is getting much better. Our YouTube downloads and options are getting better. Park and walking, if people perceive that as being safe and beneficial, we've been much more open to that. So right at the start, there was a bit of me that was so excited about everything that would be fast-tracked by this. And then with everything that COVID brought, we've hit highs and lows and frustrations and banging our heads over things will never be good again. But actually they will be. We will get there, and we'll have more opportunities and options for people than we've ever had in the past. So, barriers to physical activity, though, you're right, the weather. The weather's a huge one. And if you want it to be a barrier, it will be. But to make that easier for some of our service users, sometimes they just wind down the window and listen to us, and we get wet and soaked and spend the rest of our day in wet pants.
I love that. And do you know, I just remember, I think this is something inherent in you. When I was brought up as a kid, you're probably the same. You know, if you didn't do anything in the rain, you would do nothing. You'd do nothing in Newcastle because it rained every day almost. Like, so it's kind of that inbuilt, wrap up warm, you know, don't get cold, keep active within your limitations. But there is a lot of, when I've discussed this with other colleagues about outdoor rehab, outdoor exercise, that is a big thing. Oh, it's too cold for them because they have cardiac conditions and they might catch a cold. And there is this worry if we're introducing that as healthcare professionals. So what advice do you have for clinicians who are quite fearful of that?
I think we as clinicians go into two different camps. We have very, very risk-averse clinicians, and it's absolutely fantastic to have risk-averse clinicians in teams because they keep people like me who are not risk-averse under control. So I think a balanced team approach, bringing all the skills. We should never have a team made entirely of like-minded people. We should have a variety of people who want to operate in different ways. That's how a team is creative and safe. So I welcome everyone with different views.
Now, on the safety side, there is a couple of questions coming through about monitoring. And specifically heart rate monitoring, and then the second part of that is what do you do if someone has become unwell during a class? I know you've touched on this, but I suppose it's really just how do you monitor the patients effectively, and then what do you do?
Okay, so one of the things is it's not a class, it's a facilitating them self-managing their physical activity. So right from the outset, the information that they get is that it's not supervised physical activity with any monitoring, and the cardiac patients never have somebody walking with them. So last week we had a person out their walk and we could see them and they took a particularly long rest, and that did facilitate one of us to head out and over it and to do a check and make sure that they were okay. But that is not something that we would routinely do or head out or monitor them. And the only reason with the upper GI patients that I go out and walk with them is that their needs for information are much less acute. They've gone by that stage. They're on a low mood trajectory, so the facilitation of improvements in mood through walk, a talk, distraction, it's not about being fit and breathless, it's the lifting of mood and using physical activity to do that. So we're never offering to monitor them during this. We had a long discussion with RESA, and they asked not to, that it wasn't required for the work that we were doing.
Well, I mean, I think that's just beautifully explained the whole concept of what you're offering, and lots of comments about how powerful it is, how amazing it is, inspirational. I mean, I've had this thought concept, and when I heard you were doing this, when Heather reached out and said, oh, actually, have you seen the amazing work that's going on? I said, no. And so we have to get them to speak. We'll have to get Jane to speak, because the reality of doing is really important. And like we've heard many times for these patients, doing nothing is not an option. So what one bit of advice, if you take yourself back to that slide that really struck a chord with me, I have a simple idea, but the reality of implementing it is incredibly difficult. What would you say to those people out there that think, yes, I have a population of patients that this would be perfect for, but I'm hitting barrier after barrier after barrier? Where do they even start?
It's that thing of not taking no as an answer. It's finding out their barriers to making it work. So if they tell you they want a SOP, if they tell you it's got to go to a particular committee, it's doing all those things that get the SOP right for them, get the risk assessment in place, and do everything that they tell you to do so they can't say no anymore. I
absolutely love that. You give them the opportunity and you tell them they can't say no. You provide them with everything someone might come back with, you have an answer for. You're prepared, it's strategic.
Yeah.
And the most important thing that you've done throughout that presentation is remind us all that it's about the patient, it's about the person. And it's not about necessarily what the clinician thinks is right for them and what the clinician forcing them into this pathway. Like you said, we were almost forced to go down this digital virtual route as the only option. But actually what you've demonstrated is that there is other options and you are doing the do. So really well done to you, Jane. Thank you so much for spending your time. Like I said, lots of comments coming through. Really appreciate it.
Thank you for the opportunity and best wishes to Sam for her presentation as well.
Thank you, Jane. So I'm so delighted Sam is here, like bang on time. This is going far too well. So for those of you that don't know Sam, she's an absolute superstar in this field, and there is no one better, in my opinion, to give this talk today about alternative models of PR, because she and her team, very much team player, aren't you, Sam? Have been exploring this concept for some time. So I'm not going to steal any more of your time, Sam. I'm going to hand over to you and just ask you to share your screen, and you can do a proper introduction yourself.
I shall attempt to share my screen. I'm not quite sure how to follow that introduction. I'll do my best though, bear with me.
Perfect.
Lovely. So hopefully that'll start showing the slides. It's been very slow. Right, thanks for the introduction, Rachel. My name's Sam Pilsworth. I'm a consultant physio. I work up in Liverpool, and all my work is within the Knowsley community respiratory team. And as sort of Rachel explained, it's very much a team effort, this, and it's just, I'm going to share with you the journey that we've been going on as a service probably for a number of years now. So this goes back pre-COVID, and it's something that we've continued to think about and deliver whilst COVID has been running. So we all know what pulmonary rehab is. We all know the benefits of rehab. We all know, what an evidence-based treatment modality is for patients with chronic respiratory disease. But I'm just going to go back and have a little look at some of the definitions of rehab, because when I sort of started working within this field, these were some of the key points that made me think about how we're delivering services and are we delivering in the best way for our patients. So this is the ATSERS definition that was produced in 2013, and I've highlighted some of the key phrases that stood out for me when I was looking into sort of rehab and starting to specialise in this field. So it should be patient-tailored therapies. It should promote the long-term adherence of health-enhancing behaviours, and that last statement is something that I think we probably don't do terribly well within the rehab field. If you work within rehab, you'll see those, those constant revolving door patients that come back to you year on year, because when we complete their rehab, they've progressed, they've done well, they're walking further, they're less breathless, but then when we discharge them from services, they stop everything and then they come back to us in the same state or a worse state. This is the BTS guideline definition of pulmonary rehab, and again it talks about being individually tailored. Treatment should be designed to optimise a patient's physical and social performance, and we know this guideline is out for discussion and update and currently being updated. And then the last one I've looked at is from the NICE COPD guidelines, which were more sort of recently looked at, and again it talks about PR being a multi-component, multidisciplinary intervention, again, that's tailored to that patient's need. So those are the things that made me think about, our existing rehab services, do we tailor ourselves individually to the patient need, or do we force patients into this sort of rehab pathway that might not actually address their own individual challenges? So I found myself very much at a crossroads in life and where to take my sort of clinical practice. Do I continue with the old ways of doing things, or actually do we stick our head above the parapet and do we try and do something a little bit different? And then I found this Albert Einstein sort of quote, and it's saying that, if we keep doing the same thing again and again, we're going to keep getting the same results. And I didn't want to keep getting the same results for my patients. I wanted to do better. So I knew I had to do things differently. This looks at data I'm sure you've all seen before. So this is the 2015 PR audit data. Unfortunately, it only covers data from England and Wales, and it only looks at patients with a diagnosis of COPD. And we've got no idea of how many patients with asthma, ILD, bronchiectasis are coming through our rehab services. Now, we know actually that we're not very good at referring patients into rehab, which you can see on the left-hand side of the slide. But we know even though when patients do get referred in, we lose high numbers of patients along the patient journey, and less than half of those patients who come for an assessment will then go on to complete their pathway. So although we know how life-changing PR is, actually we're only targeting a very, very tiny proportion of the patients that would benefit from our input. And this is a massive driver for me, that how we've designed services and how we deliver services to this patient group, it just doesn't work very well. So what did we do? So we went to speak to the patients, because they're the people that access our services, and I could design something that I think is brilliant, but actually it's a nightmare for patients to navigate, to access, and it actually doesn't deliver what they need. So we went and we held loads of focus groups. And what this sort of theme that came up over and over again, that actually this traditional model of PR they found was quite restrictive, it was quite off-putting, and it didn't fit sort of particularly around their lives and their needs. And interestingly, there's been a paper just published earlier this year by the group in Cambridge, which sort of very much echoes those themes. And what came out, that one size does not fit all for patients. There's not one way to rehab a patient, and we need to design these services that can be flexible to meet those sort of very different patient needs. So what have our drivers been for change? Well, there's all the audit data, which shows that we don't deliver rehab very well to many patients. There's lots of research that shows the barriers and challenges to rehab. And then we had all the drivers that came out from our focus group interviews. So I've got some of the drivers that we needed to change, and then I've got some of our solutions that we hoped would make a difference. So we knew that we've got quite poor completion rates, and we know a lot of services quite local to where I am. Commissioners sort of very much dictate on what it counts as a completion, so patients have to attend 80% of their rehab sessions. So we've moved very much away from that in our team, and what we use is goal-based outcomes. So when patients come for an assessment, we set them SMART goals, and that's how we quantify whether somebody has completed rehab, whether they've achieved their goals. And it's a little bit irrelevant whether they come to all the sessions or half of the sessions. As long as the patient has got out from our services what they need, they have completed. So we've got really low referral rates into rehab, and we know some of the barriers people hate, other healthcare professionals that refer into rehab services. They hate filling in forms, it puts people off. So we've really tried to sort of get rid of all those barriers. So we will take self-referral from patients, we will take referrals from any healthcare professional within primary and secondary care. We're very lucky in our service that we use an integrated electronic patient record. We use the EMIS system. So we've got direct access to primary care records, and we can access secondary care records as well. So we actually don't need referral forms. We can take tasks on EMIS, and patients can contact our service themselves. So we're wanting to make that process as easy as possible. We know we've got low uptake rates, and patients have told us that they've said no to rehab because they perceive that what we're going to make them do is too high intensity for their current ability. So what we've done is we've very much taken this menu-based approach, and I'm so happy loads of people have been talking about this today. It's really made me smile. And what we do with the patient and with the person who's doing the assessment is we will discuss all the various options that we've got that we can support them with. So the patient has choice in their rehab journey. And we find if the patients have got choice, they're much more likely to continue with rehab, and they're much likely to engage in our services. And we've found this has been a real revolution. We know that there's challenges with really high levels of social deprivation with patients with chronic respiratory disease. The two go hand in hand, and we've also got transport issues, again, getting patients into groups. So even before COVID, we'd pulled all our services out of hospitals. We don't have any hospital venues anymore. We have 5 community-based venues in sort of various leisure and community centres, where pre-COVID we were running 6 different groups a week, and that would cover Monday to Friday, mornings and afternoons, to get a wide wide variety of convenient times for patients. We had a very busy home PR service even prior to COVID, and we would go anywhere, and some of the places that we've been to are represented on the map. There are some gaps in the area, and that's because we've got big industrial sites in the north, we've got farms in the south, and then we've got Knowsley Safari Park in the centre, so we tend not to go there too much. And then a bit like sort of Jane was talking about, we've looked at alternative exercise venues, so we've been doing lots of outdoor exercising, so cycling, walking groups, and we sort of did that pre-COVID, but these have become really popular during COVID as well. All our centres are on really good bus links. They've got large car parks which are free, because we're wanting to, again, to try and get rid of those barriers for patients to come. We know anecdotally, again, patients don't want to commit to coming to rehab because they get, regular flare-ups of their chronic chest conditions, which means they might not be able to attend classes. With some services, if they aren't able to continue for a couple of weeks, they might get discharged, but we have a seamless sort of rolling programme, so patients can come in and out of service at any point. They can pause rehab for a few weeks if they're, exacerbating with their chests, and then they can seamlessly enter when they're well enough and carry on their rehab pathway. And we know patients talk about the fact that services can be quite inflexible, so we've tried to make ourselves as flexible as possible to meet that patient need. So we will do whatever is reasonably practical to support a patient to come into rehab. We'll do evening sessions, weekend sessions. We've taken patients swimming, we'll take them crown green bowling. We want to get them active. So our pathway is constantly evolving, and it is very much a team effort, and you can see some of the team on the picture there, and they are all pre-COVID photos, don't worry. But once a patient is referred into our pathway, they'll all receive a phone call. It's just to ensure that the patient knows what they're being referred into. They've agreed to the referral, and then if they're unsure about whether pulmonary rehab is the right option for them, all the staff are trained in motivational interviewing techniques to see if we can engage patients to sort of engage in rehab. If rehab's not the option for them, then we can signpost them at this point to whatever their needs are, whether it's smoking cessation, falls groups, equipment ordering, or a referral straight into our community exercise scheme. Patients who do continue their pathway come for a comprehensive assessment and goal setting. And then at that point, we'll discuss the menu of options, and we'll jointly make a decision on which elements of the service they're going to access. We're also using patient activation measures, and what we're going to be trialling in the near future is that if patients are highly activated and engaged in looking after their health, then we can offer them some lower contact interventions, and those patients that are perhaps are less activated and they're less able to manage their health condition, we'll offer them a more structured, more supportive programme. So we're really tailoring all our support to what that patient needs. Patient will then hopefully continue with their rehab journey, and we'll get to discharge them. And again, they get a thorough discharge assessment and referral into our community exercise schemes. So there's lots of different colours, and it's quite a busy slide on purpose, this one. So this shows some of the pre-COVID and newer COVID interventions, really. But what the team are trying to do is that we're trying to seamlessly marry up all that, all the research and evidence base of rehab, while we're trying to, incorporate these core components of rehab. Staff have taken on extra training, so we've got dedicated smoking cessation staff within the service. We've had a lot of our team go through their non-medical prescribing, so we can optimise medications. We carry PGDs, so we can detect and manage acute exacerbations, and we've got someone who's currently training as a mental health link worker, so we can quickly spot and direct patients on to other services if they need it. Now, all the long list on the left-hand side is some of the options that we do offer within our community pulmonary rehab team. And I know this was touched on earlier. So prior to COVID, when we were offering our circuit-based classes, we did have a combined cardiac and pulmonary rehab class. And we've had that running for a number of years, and it's been really sort of beneficial. It's enabled us to get patients with perhaps really complex comorbidities through the service, whereas perhaps we would normally exclude them from pulmonary or cardiac rehab. The things in red have become more evident and sort of more popular during COVID. And then some of the things that we were hoping to develop, we've had to delay. So just prior to sort of COVID, we were planning on launching walking sports, such as football and rounders, and a singing group. And I know that's going to be talked about later, but these are sort of slightly on the back burner, but they'll still be going ahead in the future. So how are we doing? So I thought I'd compare sort of how we were going as a service to some national audit data. So this is the PR interim report from 2019, and it shows that sort of 58% of patients are getting sort of started, well, getting assessed for PR within the 90-day target. About 60% have an improvement in exercise capacity, and slightly less than that have an improvement of health status. And I've just sort of highlighted here that, again, substantial numbers of patients do not complete PR. And this isn't surprising because we haven't changed how we deliver PR. So it's going back to and thinking about little Albert Einstein. If we don't change how we're doing things, we're not going to get any different outcomes. And the reason for non-completion is multifactorial, and we have to consider that as services. So how are we doing within Knowsley? So these are pre-COVID data, and we're in the process of analysing all other patients that have been through sort of since COVID has started. But roughly on average, our team gets about 1,000 referrals into PR each year. Our average length from referral to assessment is about 8 to 10 weeks, and then usually the patient starts their rehab journey the following week after assessment. For those patients who accept a referral onto PR, 94% go on to start rehab, and of that sort of cohort, 90% do complete our programme. We've got an average increase in our 6-minute walk test of 89 metres, and about 85% of our patients do show that there is an improvement. There is a reduction in their MRC, and about half of our patients show a 1-point reduction. We get an improvement in CRDQ in all domains, and again, that's about 70% of our patients. And we are showing that we have an increase in PAM score by more than one level, and that's about 40%. So you can see that the outcome measures look good, but do the patients like it? Well, as you can see, we get really good sort of feedback from our patient satisfaction, and we have lots of regular patient engagement. Pre-COVID, we had 2 sort of patient engagement events per year where we'd invite as many patients as we could to come and sort of share their, their experience of accessing not just rehab, but our wider respiratory service. And we wanted want them to share their thoughts on how we can improve, and we take patient feedback really sort of seriously. The picture on there you can see is from our annual Santa Saunter, where we do a walk with our patients, and we get lots of sort of local services to come in and speak to patients. So we're building those social links and those community links, but unfortunately I don't think that'll be happening this year. We need to think of a plan B. So what are our next steps? So we're looking very much on an STP footprint of how we can help other services to go through this same service redesign that we've gone through. And this is some data that I presented at the BTS last year, looking at pulmonary rehab services in Cheshire and Merseyside. And following on from that, we're working together with all the PR leads on how we can redesign services, taking very much sort of the steps that we've gone through in Knowsley to make services that patients want to access and utilise. So we're very much in the planning and expanding phase. So the evidence, so we know that innovation will always be ahead of research. And when I talk about this, people always say, but there's no evidence for what you're doing. Well, when you innovate and you're ahead of that, there won't be evidence. But what we have to be very mindful of is producing that evidence, and evidence is coming. And we know that if we offer patients different things, then we will engage with patients who wouldn't have traditionally engaged with our services. And that's the whole aim of it. We need to enforce to people that actually the worst thing they can be doing is not doing anything. So there's some evidence. And I just wanted to finish off with this article here that looks at the past, the present and the future of rehab. And I feel that we very much are in the future of rehab, because what rehab services need to be doing is looking and providing their services within different settings. This needs to be adapted to the preference of the patients. and that it should be geared towards engaging more patients in better tailored programs, and healthcare professionals need to be well trained to do this, and that the individual needs of our patients need to be met. And if we don't do that, this is what I feel we're resigning our patients to. So I just wanted to say thank you to my team, who are very tolerant of me. And any questions?
Wow, wow, wow. So I have a disclaimer because I'm a massive fan of yours, obviously, and I have a massive disclaimer because I know I've been known about this work you've been doing for a little while, and I honestly think this is the future of commission and rehabilitation. And if we want to define it as respiratory or cardio-respiratory rehabilitation, then that's fine. But actually, you know, some of our post-hospital patients that aren't allowed to get rehab because they don't fit into a diagnostic criteria or condition or diagnosis or pathway that's defined by evidence, that I honestly think this is a model that can be replicated throughout the UK. So I just want to share that disclaimer there. There's some really important questions actually, and I know you get asked this all the time, and there is it's almost rigid pulmonary rehab model, isn't it, that because it's so heavily evidence-based, it's so heavily cost-effective, it's around a model of prescription that's clearly defined. So what you're doing is turning all that on the head, and you're actually saying, well, for the percentage of patients that aren't going to comply with this, that aren't going to engage, that's not what they want, we're going to ask them what they want. But some of the services, the way they're commissioned and set up, it is only for pulmonary rehab. So how do even, and this is a huge question, like how do you even get started with that? But then some people are asking, how does that fit in with recording, for example, of the audit data, national audit data? Like how do people get around that?
Yeah, I'll start with the easy bit first. So the national audit data is quite challenging because it's the OPD only. So it's just a bit of a headache for the staff who are then sort of consenting patients to remember which ones you consent and which ones you don't. But it's nothing that's insurmountable. I think for the other parts, I think COVID has the potential to be quite helpful for that. I know sort of like when we're talking about commissioning, the commissioners have lost a lot of their current powers with COVID, and everyone's been put on sort of like emergency powers. So, now's the time for people to actually have those conversations with commissioners about, okay, that's what our service was, but perhaps it wasn't working very well. And you can start to have those conversations about what potentially you think rehab services should look like. And at the end of the day, if you're delivering those services, you're the expert in that. Commissioners aren't necessarily the experts in what rehab services should look like. It is challenging. I think if you can go with sort of like supporting evidence of other services that do things differently and you can demonstrate clear benefits, then that helps. Going with lots of patient engagement is key, because commissioners, when they are redesigning and commissioning services, they should be engaging and having PPI involvement right from the start. And if they haven't, then that you need to be challenging them on that. And if you've got PPI sort of work going on that supports your redesign, then that is helpful. Also, the long-term plan is really helpful in that, I think, because it's talking about sort of working together and working in new integrated care systems, and we can't be working in these silos anymore. It's a waste of time for staff, it's a waste of time for patients. Patients don't want to be accessing 25 different services to get their rehab needs met if it can be delivered by one team.
I mean, I completely, the concept is almost too simple. The concept of it's like going into a supermarket and being able to get what you want if you're on a diet, I suppose. This is the supermarket version of rehabilitation, isn't it? And for me, it's I think the evidence thing is always what comes back. It's always the evidence argument, isn't it? Now, Again, turning that on its head a little bit, because I know, Sam, you're a massive fan of the MDT in terms of exercise physiologists, exercise technicians, OTs. So this is about the experts in rehabilitation defining a model that will meet patients with complex, or sometimes non-complex, cardio-respiratory conditions. So then you think, well, what's the harm in that? What's the harm of letting the experts, whether they may be defined by degree or training, actually coming up with these concepts? Do you think COVID's the enabler here? Do you think COVID is, like you just mentioned that?
I think it should be, definitely, because I think COVID's made people think about that actually we probably could do things a little bit differently, and it's been quite good at that. And sort of like you were talking about before, you know, people have been allowed to do things that perhaps they wouldn't have been able to do because of COVID. So it has enabled lots of people to try things and have the courage to do things a little bit differently. And what would be a terrible thing is that if that all stopped sort of as soon as everything settles down, people need to, you know, have the courage to carry on those innovations, because that's when services change and things will be different and you'll have drastically better outcomes. And it's going back, you know, to Albert Einstein again, if we continue doing things the same way, you know, you're always going to get the same results. And we don't want the same results, do we? Because we know how we've been doing things doesn't work for a vast majority of patients. And it's not ignoring all that research and all the evidence, because it is highly evidence-based. We know that it's cost effective. It's trying to marry those two things up a little bit. So quite a lot of our patients, they will come and they will have one session, and it will be more of your traditional circuit-based session. So they might have one session of that, but there were other couple of sessions are doing things that are a little bit different, because we know that to get the most benefit, patients have to continue this long term, and we know that they don't because you're not going to have that circuit support twice a week when you've finished your rehab session, so you can't really continue that once rehab finishes. So you need to sort of seamlessly support them to find exercise and activity that they want to do long term.
I mean, yeah, the way that you just describe it is so clear. It has so much clarity and just purpose. I think I'm hoping that everyone that's listening to this is really reevaluating their service. Obviously you're in a consultant physiotherapist role. I think that does give you additional power of persuasion, if you like. Another reason why these posts are so important, because you do clinically lead a whole entire service. And I know the medics that were behind your post were very clear on that, weren't they? They've very much given you the autonomy to do that. There's a few questions coming through just about your opinion, please. So in terms of, you very much said you have this menu-based approach, but also put PR as part of that. So in terms of restarting from like face-to-face PR, especially because you have other options, what would your advice be on when to start? Now we've heard that some services are up and running, but when's a good time?
Now's as good time as any. I think it depends on lots of things. It's not just as easy as that, unfortunately. We were just about to start going back to some face-to-face classes when sort of like we went into Tier 3 lockdown as part of the Liverpool City region. Now, our Liverpool City region lockdown was stricter than some of the other Tier 3 lockdowns, so we had to close gym and leisure centre facilities, whereas other places didn't have to. So we were just about to sort of get back to going to sort of face-to-face group sessions when that happened, and all our venues, we lost them because we don't have any hospital venues. So we would have gone back then at that point. I think because lots of our patients had shielding letters, that was coming to an end. That would have been a good time to sort of start to restart things. And unfortunately, obviously, we went back into Tier 3, then the gyms opened again, and now they've shut again. So what we've been really keen on doing is that actually what we need to do is to provide sustainable rehab services, regardless of what lockdown level people were on. And if that's meant that we've had to sort of delay some of the face-to-face groups for a little while we can sort of onboard and get get people supported in a slightly different way, that's what we've chosen to do, because we know COVID isn't particularly going to go away anytime soon. You know, we've got to learn to live with this. So what we need to do as services is make sure that we've got, you know, sustainable things, because what we can't do is go back to everything shutting down again and us not offering patients anything, because that's not acceptable.
So how do we reassure patients? How do you do that?
A lot of it's done on with phone calls. I think, you know, that very early sort of engagement with the patients. A lot of them are a little bit nervous about coming. Well, they're quite, to begin with, they were very nervous about us going into their homes, and it's sort of explaining sort of all the safety checks that you do that other people have already gone into today. So there's pre-COVID checks, you know, staff are wearing the appropriate PPE. We've obviously had big mass screening in Liverpool, which I think has helped a lot of people. And now our trust, and I know a lot of other health trusts are starting with the staff screening twice a week. So I think that will help to alleviate patients' fears. And it's just having those honest conversations with people, that actually, you know, the most harmful thing you can be doing is not to be doing any form of exercise, and that's much more harmful and carries a much higher risk than a low risk of you perhaps potentially, you know, catching COVID from a COVID secure, you know, environment. And it's, as the other, you know, people have talked about, is making sure you've got all your infection control policies, you know, in place, and working with, you know, your sort of location providers, because everybody wants to provide good care for patients.
I think that's certainly the key from my local experience is, you know, just give it a try, come on, see if you feel safe. And then once you see the very strict IPC that's being followed, and you see the mask change, so say it's just like a fresh mask when you arrive. We've started to introduce visors if people want them as well as just a second line of defence. So, and then seeing the staff in full, you know, level 1 PPE. So yeah. I agree. Sometimes it's kind of like just reassuring them and say, just come along and have a look at what it looks like.
Yeah. And I think because we've offered all those sort of extra things, you know, they can see that we are taking those precautions really seriously. So a bit like Jane was saying, you know, our outdoor walks have been one of the most popular things that we've developed, and come rain or wind, patients would turn up. And we did get some questions from management about why you're taking patients out in the wind and the rain. But actually, you know, they face that weather all the time, and if they can have that healthcare professional supporting them to manage their, you know, their breathlessness and their breathing pattern, while, you know, it's that proper lived in sort of real world treatment, isn't it? Whereas you don't get that if you're closeted away in a gym in the hospital somewhere.
Oh, I completely agree about this outdoor walking thing. I completely agree, and that was a whole concept of green space in the parks, definitely. Now I'm just going to touch on a couple of questions. I'm aware of time. Can we still call it PR if it's not 2 sessions a week and 6 weeks of supervised exercise sessions? Ursula thinks so, but do commissioners in the RCP?
I think so. But quite often they do have supervised sessions, and you don't, you know, the supervised session doesn't have to be in a gym doing a circuit. You know, walking somebody outdoors is a supervised exercise session. So they very much get those. It's like anything, it's open to interpretation, but our patients, they have 2 supervised sessions a week and they have their home exercise plan. It's just what we class as a supervised exercise session is a different form of exercise.
Yeah, and I think Sarah's put a comment up here about the national audit feels like a barrier to change. I know so many people feel that, and the audit as well. And it's not, it's way beyond this presentation to discuss all that in detail. But I think that's what the people at the top have to do. I think that's what people like you, the change agents, diversity of thought, need to come together and say, actually, yes, this is a really great bit of rehab that will provide, but you know, whatever percentage it is, the 80% of people, what else can we provide? So, and just a couple of other comments about long-term adherence to exercise at home has improved using remote frameworks as opposed to community-based venues. So this crossover between virtual delivery, you know, face-to-face delivery, and then alternative models, I think is the only way.
It is, in our new pathway that we're developing for Cheshire and Merseyside will very much reflect that. So at every sort of like stage of the patient journey, they'll be able to, you know, select between sort of face-to-face and virtual rehab, and patients can mix and match, and that's what we have to do, because we have to get mass appeal, we have to get more patients through, and that is the only way to do it.
Well, we are bang on 2 p.m, so I am really grateful for your time and for being on time. You are just so inspiring and amazing, and thank you so much for everything you're doing in this area. Lots of nice comments.
Great, so thank you for asking me.
Of course. We have a 15-minute break, so I want everyone to stand up and do a bit of exercise, get a bit of fresh air.